And now I'd like to introduce Isabelle Cisco with Lincoln County Public Health. Isabelle is a graduate of Oregon State University with a Bachelor of Science in Public Health, Health Promotion, and Health Behavior. After graduation, Isabelle accepted a position with the AmeriCorps Vista, relocating to Anchorage, Alaska for a year of service with the Alaskan Native Tribal Health Consortium. During her year in Anchorage, she worked with specialists, providers, nurses, and support staff in the liver disease and hepatitis department on unique projects involving a variety of different liver diseases, but focused mostly on her work with hepatitis C. She created comprehensive patient provider education on HCV and took a point in coordination of 2 large conferences to train primary care providers around the state on how to treat hepatitis C in their practices. Additionally, she worked with support staff during field clinics out in the regional hubs and attended regular meetings with the Alaska Hepatitis Advisory Work Group, creating a strategy for statewide Hep C elimination. Following her year of service with AmeriCorps Vista volunteers, Isabelle accepted a health education specialist position on the harm reduction team with Lincoln County Public Health. She is a regional coordinator of the Early Intervention Service Outreach Grant that Lincoln shares in partnership with Benton and Lynn counties and the Confederated Tribe of the Siletz Indians, as well as contributor for the harm reduction and hepatitis C treatment and primary care pilot program.
Thank you for doing this, and thank you for having me. And I suppose I'll get started. So my name is Isabelle Cisco, and I work with Lincoln County Public Health. More specifically, I'm a part of our harm reduction team, and I'm here to talk about our pilot program for harm reduction plus hepatitis C treatment in primary care that we started this year. I got asked to be a part of this project because I have a bit of a background working on viral hepatitis, specifically hepatitis C in Alaska. And part of that project and part of that work was training primary care providers on how to treat Hep C in their practices. So it was pretty organic that when I started in Lincoln County, they asked me to be a part of this project, and I'm really excited to be here today and to talk to you all about it. So here's a brief overview of what we're going to talk about today. I'm going to discuss the rationale behind why we wanted to do this project in Lincoln County. Going to give a brief background on hepatitis C infections in the state of Oregon, and then we're going to narrow that scope and look at just Lincoln County. I'm going to discuss our project aims and our project description, and then give a brief overview of our funding source. And then we're going to get into our workflow. So how we establish the workflow between Lincoln County primary care, our harm reduction team, and Samaritan Health Systems, mainly their specialty pharmacy and infectious disease department. And I'll finish by talking about where we are currently and the next steps that we want to take to kind of get the ball rolling on this project. So when thinking about the specific need for doing an intervention like this in Lincoln County, there were a few points that were really important to highlight. The first of which is that in the state of Oregon, only 50% of people who have active hepatitis C infections know that they are infected. And of this, only 7 to 9% ever achieve viral suppression. And to me, I think this speaks volumes to the lack of screening and treatment, because when I conceptualize the low number of people who are being treated for hepatitis C in comparison to the cure rates for the medications that we have on the market, that says to me that we're just not screening and treating enough people, rather than treatment is unsuccessful. The second point that is important to highlight is that hepatitis C treatment in primary care has been found to be as safe and as effective as more costly specialty care. And it's important to note that in Lincoln County, we don't actually have any specialty care. Our patients have to travel to Corvallis. In Benton County, it's over an hour away. And that kind of presents barriers in and of itself. But if you belong to a high-risk population, if you're actively using drugs, if you're unstably housed, that makes the barriers for treatment impossible. And so it's really important that we're lowering the barriers and making treatment more successful, which is our second bullet point, that having treatment for hepatitis C in primary care is more accessible to people in rural areas and to people of color. In the research that we looked at specifically, we found that it's more accessible to our Latinx and Indigenous populations. So when we look at the demographics nationally for people who have active infections of hepatitis C, historically, we'd seen that these are people born between 1945 and 1965, or what are considered to be baby boomers. But over the last 2 decades, that demographic has really started to shift. And we've seen people much younger having infections of hepatitis C. This has largely contributed to the opioid epidemic and the rise of injection drug use in our country. And the state of Oregon really kind of reflects that. It's no different. In fact, the Oregon Health Authority estimates that 61% of acute hepatitis C infections in the state are among young adults, people 15 to 34 years of age, with injection drug use being the most common method of transmission. Other at-risk groups in our state include our Indigenous populations, so American Indians and Alaska Natives, people living with HIV or at risk for HIV. And when we say at risk, we mean engaging in risky behaviors. So they're engaging in injection drug use, they're having unsafe sex, they're getting unprofessional tattoos or piercings, things of that nature. Recently, incarcerated persons are at risk, members of our LGBTQ plus community, and people born between 1945 and 1965. And when we narrow the scope, looking at Lincoln County specifically, we see kind of a different picture. And I think that this is highlighted very well from the image on the screen. We know that Lincoln County has one of the highest incidence rates of hepatitis C in the state, and we're considered to be high risk for an outbreak of hepatitis C. And in 2019, our harm reduction program here in Lincoln County conducted street outreach, providing rapid hepatitis C screening tests to people in non-clinical community settings. And we found that 17% of people tested reactive for hepatitis C antibodies. So there's a significant need for an intervention of HCV screening and treatment in our county. So I want to get into talking about our project, harm reduction plus hepatitis C screening and treatment in primary care. We have 2 specific aims for this project. The first of which is we want to provide a collaborative approach to address screening and treatment in Lincoln County. The second is that we want to combine harm reduction and peer support services with accessible treatment options in primary care. And to do this, we have a few partnerships. So Lincoln County Public Health and Harm Reduction is working with our federally qualified health centers and our school-based health centers and our primary care providers. We're working with the Confederated Tribes of Siletz Indians and their community health clinic. And we're partnering with Samaritan Health Systems, namely their specialty pharmacy and infectious disease department. In fact, Adam Brady, who is the hepatitis C expert in Samaritan ID, is a part of our project, and we're super happy to have him on board. So I want to go over our project description. We have 4 primary goals for this intervention. The first is to organize the intervention, implementation, monitoring, and support processes for Lincoln County. We want to make this a self-sustaining project. We're planning on doing this by having this project eventually be billed to insurance, and so it can continue on after our funding sources run out. The second goal is that we want to establish a complete care cascade in Lincoln County. And when I say complete care cascade, I mean from the time someone gets screened in the field, in community settings for reactive antibodies, to the time that they're getting tested for the SVR12. We want to link people into care, and we want to keep them in care long enough to get them treated and cured. Our third goal is that we want to increase access to hepatitis C screening and treatment for populations at risk. And lastly, we want to increase the number of at-risk individuals who are currently in treatment for active hepatitis C infections. So I want to preface and say that I was not involved or even working at Lincoln County when we applied for this grant. So I am not the most expert person to answer questions about our funding sources. But what I can tell you is that the funding is coming from our regional CCO network, our Health Systems Transformation Network, and that it totals just over $39,000. And that if you would like to know which CCO, regional CCO Lincoln belongs to specifically, it's our Inter-Community Health Network of Lynn, Benton, and Lincoln counties. And looking at a breakdown of our budgets, we have staff time and personnel time, which is donated to this project. We're spending just over $11,000 on rapid tests for our Lincoln and Silet's harm reduction programs, and we get outcomes funding for this project. That means that each of our partners receives a small sum of cash for each of those 4 goals that we achieve. So we're working on finishing number 1 right now, and so each of our partners will receive a good sum of money when that is finished. So I want to talk about how we established our workflow in Lincoln County, and we did this by kind of breaking it up into 2 parts. We have our harm reduction and our peer support side of things, and then we have our federally qualified health centers, our primary care side of things. So for our for our harm reduction and peer support workflow, the first thing is that we want to provide rapid hepatitis C tests in non-clinical community settings. It's important to note that our outreach worker, Cedar, she is fabulous, and she builds rapport and relationships, and she builds trust with people. And a lot of these people belong to communities at risk. And so having that moment of readiness, having that trust established with Cedar, and being able to say, yeah, I have risk factors, or I'm worried that I might have hepatitis C, so I'm interested in getting screened, is really important. And that leads into our next point, is that if someone comes back or tests reactive for hepatitis C antibodies, Cedar is able to discuss with the patient about treatment. She's able to assess their interest in getting treatment, and she's able to identify any barriers to treatment that they may have, whether that be health insurance, transportation, a support system through treatments, whether they're enrolled in OHP, Oregon Health Plan, which is Oregon's version of Medicaid. And we're estimating that a large majority of people who will be participating in this project are eligible or currently enrolled in OHP. And another important note is that Cedar is qualified to help them enroll. She knows how to do that, which is something that we really talked about being important in this project, is that we wanted to be able to ensure that people who are eligible for OHP have someone to help navigate them through that process. And the last bullet point is that Cedar, our outreach worker, and the outreach worker at the tribe are going to provide navigation through confirmatory testing, the intake process, which we'll talk about briefly on the next slide, and appointment setting, and getting them set up for treatment. Looking at our workflow in Lincoln County primary care, we have several goals. The first is that we want to establish a policy and a protocol for treatments, labs, and billing processes in our primary care system. The second is that we want to create a lab-only standing order and a billing process for that lab-only standing order for the confirmatory testing on its own. And this is important because when we were discussing how we wanted to do this, we realized that there was a huge barrier between having someone establish that moment of readiness in the field with Cedar, wanting to get screened for hepatitis C. If they come back reactive, taking them to primary care, and then having to wait 4 to 5 days for an appointment just to see if they have an active infection, we were going to lose a lot of people. So one of the things that we really wanted to be sure we established in our workflow was having a standing order or a standing appointment so that they could go into primary care without an appointment. They could get the blood draw for the confirmatory testing. And if they weren't already enrolled as a patient at our federally qualified health center, Cedar could help them navigate that process while they're there doing the blood draw. And that was really important to make sure that we lowered that barrier and access to treatment so we didn't lose people between screening them in the field and getting them started on this treatment regimen. The third goal is that we wanted to schedule follow-up appointments. This is for fibrosis assessment, additional labs, pre-treatment labs required before treatment starts, an official diagnosis, and then treatment recommendation. The next bullet point is that we want to refer these patients to Samaritan Specialty Pharmacy and Samaritan Infectious Disease for e-consult. So our specialty pharmacies, and we'll talk about this on the next slide when we discuss their workflow, but they're helping to ensure that the recommendation for treatment and the medication is correct. They're helping mail the treatment to patients, and they're really assisting in kind of the logistics behind how we're getting this treatment regimen in primary care off the ground. And lastly, our primary care providers want to provide follow-up. So they want to see the patient midway through treatment at week 4 or 5, when treatment ends, usually around week 8, and then after treatment, 12 weeks for their confirmatory SVR testing to ensure that they were cured. So I want to look at Samaritan infectious disease and their specialty pharmacy workflow. The specialty pharmacist is going to contact the patient and review the treatment plan. Namely, they're going to go over the medication recommendation, how the medication works, discuss any possible side effects, and they're going to talk about drug-to-drug interactions. So how that medication might work with other medications that the patient is taking. What's really great is that the specialty pharmacy is helping us submit the medication prior authorization to overcome the cost barriers for treatment. I think that this is a really important point because they have experience doing this, and our federally qualified health centers and our primary care providers don't, specifically for hepatitis C. So the fact that they're doing that and helping us overcome cost barriers so that people can get into treatment is, again, lowering the access into treatment and helping people get cured of hepatitis C. They're mailing the medications, the patient education, and the treatment plan out to the people in this project, and they're providing follow-up care and care coordination during treatment. So they're doing a 1-week check-in on side effects and med adherence. They're sending out reminders to patients about refills that are needed, and then of course they're providing those medication refills when the time comes. And our next steps. So this is where we are currently. We've established our workflow between our harm reduction team, our primary care, and Samaritan. And where we're headed next is we're following up with Lincoln County Primary Care for implementation. We're going to write our policy and protocol for our treatment, our labs, and our billing processes. We're going to provide 2 specific trainings to all harm reduction, communicable disease, and primary care staff. The first of those trainings is a HOPE training, which is provided by the Oregon AIDS Education Training Center. HOPE stands for HIV, hepatitis C, overdose prevention and education training. We want to make people familiar with injection drug use. We want to make them familiar with how hepatitis C treatment is going to work. The second training is a SELECTS cultural competency training. We want to make sure that the treatment that we're providing is trauma informed, and we want to make sure that our providers know about how culture can be curative and preventative, and how engaging in culture during treatment makes treatment more successful. The third next step is we want to repeat this process with our SELECTS Community Health Clinic based on their unique needs and systems. So we want to establish a workflow between them and Samaritan. We want to start the monitoring process. So we want to get people into treatment and start collecting the data on how successful this intervention is going to be in Lincoln County. And with that, thank you for having me, and I will take your questions.